Innovations of Tuberculosis webinar series. Thank you for joining us. We're just going to pause briefly to allow everyone to get fully connected here. So while we do that, could you please introduce yourself in the chat by sharing your name, your professional role, and the state you're from? We appreciate the participation of clinicians, public health professionals, and partners from a range of settings, and we thank you for your ongoing work in tuberculosis prevention, diagnosis, and care. We'll get started shortly here. Hey, welcome. We have a wide variety of people from all over the country. Alaska, welcome. Florida, nice. Welcome, everyone. Okay, I think we're going to be respectful of time and we are going to get started. As people keep joining, you can, they'll just drop their names in the chat. So like I said, good afternoon, everyone, and welcome to today's session of the 2026 Innovations in Tuberculosis webinar session. We're pleased to have you with us as we explore asymptomatic TB or subclinical TB. Throughout the session, we encourage you to submit your question using the Q&A feature. Time permitting, our speaker will address them at the end of the presentation. Following today's webinar, you'll also receive a follow-up email with access to the recording, presentation slides, directions for claiming credit, and additional resources referenced during the session. But before we begin, it's my pleasure to introduce today's speaker, Avish Nagpal. Dr. Nagpal is a highly regarded specialist in infectious disease. He earned his medical degree from Kasturba Medical College in India and a Master of Public Health from Western Kentucky University. He completed his internal medicine residency at University of North Dakota, followed by a fellowship in infectious disease at Mayo Clinic in Rochester. Since 2013, Dr. Nagpal has served as an infectious disease consultant medical director of infection prevention at Sanford Health in Fargo, North Dakota. He is also a clinical associate professor of medicine at the University of North Dakota. His professional interests include infection prevention and transplant-related infections. Please join me in welcoming Dr. Nagpal.
Thank you, Denise, for the wonderful introduction. Hello, everybody, and welcome to the lunch hour. Today's session is titled Asymptomatic TB or Subclinical TB, and primarily we'll be talking about latent TB, and I'll introduce, hopefully, a concept on how it ties into the concepts of asymptomatic and subclinical TB. I do not have any financial disclosures to report. I'm not mentioning any off-label use and uh, anything else. So learning objectives are fairly simple. We'll try to define the latent TB infection. We'll try to see who to screen, when to screen, and explain the treatment options for LTBI. So pretty straightforward, something that most of you, as I'm reading your job description or job title here, I think many of you are doing this already. So hopefully I learned something from you. Um, Okay, we'll start with a simple polling question first. A 36-year-old woman undergoes screening for TB as part of her contact tracing. As her son was recently diagnosed with pulmonary TB, her quantiferon gold plus testing is positive. You see her in the clinic for further evaluation. What is your recommendation to the patient? Number one, you should cancel the patient and ask her to isolate because she might have active TB. You should obtain a PPD to confirm the results of the positive quantiferon gold plus testing. You should obtain a chest x-ray, or you should ask her about symptoms that might suggest that she also has TB, just like her recently diagnosed son. We'll give you just a moment, a couple minutes to read the question and answer it. Okay, very good. So yeah, so most of you got this right. C and D can both be correct. The answer we are looking for is actually D, because there is nothing more important in medicine than a good interview, which is what all of you are trained to do well. You can also get a chest x-ray up front. That's not a problem. I sometimes do that even before I see the patient so that I can review it in the meeting with them. So, this is not a quality tested question or board question or anything like that. That's just a basic concept, and we as infectious disease and public health providers always start off with an interview and then proceed to the investigation. But there's no harm in practically getting a chest x-ray first, even before you meet with them. That way you have more information. So both C and D can be correct. Very good. So TB, it still places a large public health burden all over the world. It's one of the oldest diseases known to us. About a quarter to one third of the world's population is infected. Doesn't mean they have active TB, just means that they have inhaled the bacteria and it's in their body. And we'll study the differences between the two, which is basically what will differentiate a latent TB infection from an active TB infection. And all over the world, we are seeing still around 200 million deaths every year. And with TB, as with every infectious diseases, we are seeing a growing threat of antimicrobial resistance. A quick word on epidemiology. This will just be a few slides before we transition into pathophysiology. This slide just shows the case rate of TB, the incidence rate of TB over the last couple or 3 decades here in the US. As you can see, we started off with a little bit of a peak here in the era of HIV infection, when we didn't have a good combined antiretroviral therapy. And then since then, or I should say, it had been a steady decline downhill since about 2020. Um, this drop in cases, I think, is a little misleading, because this was because all of you were kind of occupied with COVID quite a bit, which dropped our screening rates and case finding rates a little lower. But as you can see, it has bounced back and has even gone higher as compared to pre-COVID-19 era. So currently sitting at 3.1 TB case per 100,000 population. Um, and the slide that I showed you represented the combined TB incidence rate. But if you uh, differentiate between TB rates among the people who are US born versus non-US born who immigrate to the country, there's quite a substantial difference. And I think this is important to remember when we talk about pathophysiology as well. People coming in from highly endemic areas like most of Asia, Africa, Southeast Asia, Latin America, very, very high rates of TB as compared to what we see here. So the rate of TB incidence among US born population is actually less than 1%, but those in people who were born in highly endemic countries, that approaches almost 16 per 100,000. Um, so so quite a bit of difference there. Uh, I like this slide from CDC's latest slide set, so I shamelessly copied that. And this just highlights that most of the cases you will see among people immigrating to the country will be within the first 5 years of their immigration. And we'll touch on this a little bit more when we talk about pathophysiology and how TB is acquired and you subsequently develop a disease. This slide just shows where the TB cases and incidences is highest. As you would expect, where there are larger populations, California, Texas, New York, Florida have the highest rates. And then, We are in the upper Midwest region, so Minnesota is getting up there too. Because of the new cases, so we see quite a bit of TB around this area too. This slide just shows the rates of TB in U.S. territories. If you notice that in Republic of Marshall Islands, TB rates are extremely high, 250.3 per 100,000 people, and that relates to different factors, including dense population, higher incidence of diabetes, things like that. So rates in overseas U.S. territories are very, very high as compared to the mainland U.S. And these are the contemporary risk factors, which kind of increase your risk of developing TB. We'll talk about these a little bit more, but these are more up to date. Things change with time. We have good HIV treatments now, um, so we don't see as much, um, HIV being um, a big risk factor for TB as long as people are taking their HIV meds and as long as they are getting diagnosed promptly and treated promptly and being retained in care. So over the last couple of years, the most common risk factors that you see are actually excessive alcohol use, non-injection drug use, homelessness, residing in long-term care facility or injection drug use. So the things that are familiar to you guys with among the people that you see. Um, this is also similar, so we won't spend too much more time on epidemiology. Let's go on to the meat of the presentation here, which is transmission and pathogenesis. This is where the concept of latent and active TB becomes a little bit more clear, hopefully, as we go through the next few slides here. TB, as all of you know, is an airborne disease and spread by droplets. The bacteria that causes TB is Mycobacterium tuberculosis. This is like a group of bacteria, which includes BCG as well as Mycobacterium bovis, Mycobacterium africanus, but the 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 MTB complex as a whole with Mycobacterium tuberculosis as a single species causes most of the diseases. What does airborne disease mean? It means that when somebody who has TB coughs, um, they release the droplets in the air, and because of the size of the droplet, they can hang around in the air for a little bit. They are not huge droplets, so they don't immediately fall down to the floor, and because they hang out in the air for a little bit, the air currents can carry them a little bit more. So it's not just the person who's sitting right next to you who's at risk. It can actually affect people who are in the same room for a prolonged period of time, or in the same general environment for a prolonged period of time if you're visiting a highly concentrated area like a concert or a restaurant, something like that. So what happens when you inhale the TB bacteria? Once it's airborne and you inhale the TB bacteria, it goes down into your lungs and doesn't immediately start causing the disease. So TB by definition is a subacute or a chronic disease. It's not like you inhale the TB bacteria today and you will develop TB in 2 days. That's not a thing. TB being a chronic disease, what happens is once you inhale the TB bacteria, it gets into the lungs where your inherent immunity traps it and forms a calcified, what we call as a granuloma, a wall of containment around the TB bacteria. And 90% of the people who inhale the TB bacteria will actually remain in this stage. It will not progress any further. So TB bacteria will be in a state of suspended animation inside a granuloma, inside a wall of containment, and never they will never get TB. This is why we say that third to one fourth of the world's population is infected with TB, which means that they are at this stage, doesn't mean they have the disease. And this stage is called latent TB infection. Um, if you want to put an official definition on it, then it means that it's a state of persistent immune response to stimulation by the TB antigen without evidence of clinically manifested active tuberculosis and with absent bacillary replication. Again, it means that the bacteria is in a state of suspended animation because our immunity has localized the disease to the lung. It has formed a granuloma, a calcified wall, and trapped the TB bacteria right there. 90% of people will go to their grave having this granuloma if they get infected with TB. Only 10% of the people who inhale the TB bacteria will actually progress to develop active TB. And out of those 10%, most of the risk of developing a breakthrough TB infection, where the protective wall against the bacteria breaks down, the bacteria starts dividing again, and then starts causing pneumonia or can disseminate to other parts of the body and cause extrapulmonary TB. That phenomenon only happens in 10% of the people. And out of those 10%, the highest risk of TB bacteria breaking through occurs within the first 2 years of your life, I mean, not your life, sorry, first 2 to 5 years after you inhale the TB bacteria. After 5 years, the risk of TB reactivation continues to go down exponentially throughout your life. So if you recall that epidemiological slide where it tells you when people get TB after they emigrate to the US, this is the reason they get most of the TB within the first 4 years after they immigrate to the US, because the highest risk of TB getting reactivated after formation of a granuloma is within the first 2 to 5 years of acquiring the infection. There is a question in the chat, why after first 2 years? That's just the nature of the infection. You know, when we talk about infection, it's not just the bacteria. Infection is kind of a complex interaction between environment, bacteria, as well as your immunity. So it's like a trifecta. All three things have to align for a disease to manifest in whatever way it will manifest. So what happens after first 2 years is that your granuloma is probably gets fibrosed more, gets calcified more. So, your slow arm of the immunity, what we call a cell-mediated immunity, probably has more time to trap the bacteria in there. So the risk of it breaking through goes down with time. However, having said that, if later in life you get an immunosuppressive condition or have cancer and are undergoing chemotherapy, or you go on like immunosuppressive medications like medicines for inflammatory bowel disease or rheumatoid arthritis and things like that, um, um, your risk of breakthrough infection or reactivation will increase because your immunity will go down. Again, this has to do with the concept of infection not just being about bug, but a complex relationship between bug and your immunity. Um, Somebody said in the chat, silly question. I just want to reinforce that no questions are silly. My answers usually are. But the question is, what is the relationship between arriving in the US and reactivation? So that's actually a very, very good question. I've wondered that for a long time, and I don't know if what I think is correct, but my theory is that even though they are coming from countries of high endemicity and they may have acquired infection even in their childhood and they are coming here as an adult, I think what happens is that many of these people who immigrate from areas of high endemicity come here seeking asylum, and as part of that, they may be living in like refugee camps or something like that, which creates a very high uh, environment of very high transmission from cases of active TB. So I think that also plays a role into it. Uh, there. Um, Yeah, so stress of travel. Yeah, that probably also plays a role into it. So there are more questions and we'll get to them. So let's keep going here. I want to make sure that we address some basic concepts here and meet our learning objectives before we answer follow-up questions. So what happens with when the after we have gone through this for quite a bit. So I'll just keep going here. Um, I told you that most of the TB is reactivation after the granuloma breaks down and the bacteria breaks through and then disseminates to other parts of the body or causes localized disease in the lungs. But there is also a concept of primary TB, which means that your body is never able to form a granuloma. And what happens when you inhale the bacteria is you get a primary pulmonary TB, which means that you get the pneumonia in the typically in the upper lobes just a few weeks after you inhale the tuberculous bacillus. So that phenomena is not very common, happens rarely, but most of the time when TB occurs, it is reactivation of a prior exposure. And TB is a fascinating disease because it can go to different parts of your body. Most of the parts of the body can be affected by TB. For example, it can go to your brain, causing CNS TB or causing TB meningitis. It can go to your larynx, um, which is one of the most infectious forms of TB. It can go to your abdomen. I recently saw a case of TB actually on the left side of your colon. Usually it happens on the right side of the colon, in the ileocecal region. Um, you can get TB in your adrenal glands. You can get TB in your kidneys. You can get TB in your joints. Hip joint, very, very common. Lumbar spine, very, very common. Um, and then miliary disease means that your TB has disseminated to different parts, different, not only throughout the lungs, but also multiple organs in the body. So miliary means disease, disseminated disease. We talked about this slide a little bit. As I said, all infections are related to a complex interaction between the host, the bug, and the environment. It just, shows you in a diagrammatic form, um, and and just drives home that concept a little bit more. We won't go over this in detail because we have already talked about this. So this slide talks about that a little further and further clarifies what I mean by complex interaction between environment and the immunity and the bug. So when we talk about environmental uh, uh, issues that relate to increased TB transmission, if you have poor air circulation, so the TB is airborne disease. If you have poor circulation, droplets are hanging out in the air. It's a more crowded area with poor air circulation. Obviously, the chances of transmission would be higher. These things are typically seen in homeless shelters or areas of incarceration. Nursing homes and hospitals are kind of unique in a sense because they contribute both towards environmental and biological factors affecting TB transmission. Uh, what happens with these large nursing home and hospitals is that they have complicated, and this can happen on cruise ships too, as you might have seen in the news recently. You have complex airflows. These are large buildings where air from different rooms is intermingling. So add to that patients who are very weak and more susceptible to infections when they are in the hospital. Many of them are immunocompromised. So transmission of TB actually occurs, relatively more easily in nursing homes and hospitals as compared to other places in community. Um, Biologic risk factors, we studied some of those. Alcohol dependence, top of the list. Again, drug use, whether intravenous or not. HIV infection, one of the most important risk factors for TB. As a matter of fact, if you have uncontrolled HIV infection, uncontrolled and advanced HIV infection, which means your CD4 count is less than 200 or less than 100, your risk of TB is actually measured in number of in percentage per year. So risk can be as high as 7 to reactivation. Then it also depends on the index patients. So people who have cavitary disease, so some people will get pleural TB, not very infectious. Some people will get pneumonia in the upper lobe, very, very common presentation, one of the most common presentations of TB. They are infectious, but if they develop cavity in that infiltrate in that pneumonia, their risk of transmitting TB to other people becomes very high because those cavities harbor a lot of bacteria. AFP smear positivity, interestingly, this makes intuitive sense. If you have more bacteria in your sputum, more bacteria is being coughed out, more bacteria is hanging out in the air, the higher risk of transmission. Laryngeal TB, even if you're not coughing, you're singing, you're talking, you can transmit TB. Closed spaces we talked about. HIV negative status. This is a little bit counterintuitive. HIV positive people actually don't spread as much TB as HIV negative status. Why? Because if you are HIV positive, you don't have very good immune response, so you don't make cavities, which is dependent on how strong your immune response to an infection is. And if you're not making any cavitary lesions, or you're having more disseminated disease, or if you're having more extrapulmonary disease, which happens more frequently in HIV, you are not going to spread TB to a lot of other people because you are not coughing out as much. Also, with advanced HIV, you may be very weak and your cough is not very effective. So a lot of uh, things happen with HIV, which makes it a little counterintuitive that people who have advanced HIV infection don't spread TB further as much as compared to people who don't have HIV. Of course, if you have delayed diagnosis or if you have MDR TB, then you are coughing for a longer time, or you are taking meds that are ineffective, then there is a higher risk of transmission. Or if you put patients through bronchoscopy or induce a sputum, they are going to cough up more, they are going to put out more bacteria in the air, and it will lead to higher transmission. And this just highlights the individual risk assessment of every um, every biological risk factor that we have talked about. As you can see, um, relative risk for TB is very, very high in HIV, almost 8.3 times as compared to people who don't have HIV. So, okay. So this is one of the more important slides because it distinguishes between latent TB infection and active TB infection. Latent, by definition, means the bacteria is not replicating. They are within a granuloma. Uh, you are not having any symptoms. You don't have pneumonia. So, the patients will be completely asymptomatic. You will not hear any problems with their lungs when you auscultate them. They look okay because they are not having an active infection. By definition, they are not contagious. They don't have a pneumonia. They don't have a cavity. They don't have miliary disease. So chest X-ray is typically normal. It may be abnormal for other things. You have to be careful that you don't attribute every chest X-ray abnormality to TB. And this happens very commonly in elderly people who have cardiac disease, and they have findings that are either related to COPD or, say, CHF and things like that. Um, and that can be a little confusing or a little challenging to differentiate between those findings emanating from those diseases as compared to TB. But as a definition, chest X-ray will be normal for patients who have latent TB because they don't have active disease and pneumonia related to that. They should not be able to cough out any sputum. You should not be able to grow any sputum, any bacteria from the sputum, because the bacteria is not dividing. The bacteria is trapped in a granuloma. And the reason we treat latent TB is we are very poor at predicting who is going to reactivate the TB later in life. There are some risk factors which will give you a clue, but they don't capture everything perfectly. So you can make an educated guess. You can counsel the patient on these are your risk factors. You are at a higher risk of TB. But by definition, a latent TB can become active disease at any point in your life. So the goal of treatment for latent TB is to prevent active TB. And for that, one or two medications, as we will discuss in the next subsequent slides, are relatively, they work very well. Now, compare that to active disease. Active disease means that granuloma has broken down, people are coughing, people are spreading the disease to other people, they are contagious. You will be able to hear abnormal lung sounds on physical exam, chest X-ray. Most typical finding would be upper lobe pneumonia, either on one side or bilaterally. Some people will have cavitations if they have advanced disease. Some people will have fibrosis. They, will usually be either smear or culture positive. Um, if they have extrapulmonary disease, you have to do a biopsy and culture that tissue uh, to run the susceptibilities. And if you have active disease, you are typically on treatment with at least 3 or 4 active drugs against that particular organism, depending on susceptibility results. So now I want to highlight another important concept. Whenever we talk about an infection, it is usually a continuum. For practical purposes, we tell you that um, there is a latent TB and there is an active TB because that's how you manage the patients. But there will be patients who are in between latent and active TB. We call this either asymptomatic TB or subclinical TB. This is why the title of today's talk is asymptomatic or subclinical TB, because that's a more accurate representation of the entire spectrum of TB disease. So latent TB disease means absolute 100% no bacteria dividing. Active TB means bacteria dividing, they have a disease. But sometimes, maybe it's early part of the disease, maybe they have um, a milder form of disease. They may not have very many symptoms, but they still have active disease, and you'll be able to figure that out either by doing imaging or um, what you could also do is, do a biopsy if you find something abnormal based on your physical finding or imaging finding. And then when you put them through, they may be negative on your usual microbiological studies like stain and culture, but you'll have to do some other diagnostics like nucleic acid amplification or a PCR, or what we do now, next generation sequencing or metagenomic sequencing. So you have to use molecular techniques sometime when the difference between latent TB and active TB may not be as clear cut. There are some people who develop active TB disease, but they resolve their infection on their own, just like you can resolve your influenza or COVID-19 sometimes. That rarely happens with TB too. So where do you place them on the spectrum? And there are people who will intermittently activate their active TB, body will try to control it, and then they go into latent phase again, but they again reactivate a few years later. They may again control it, may not again control it. That's called cyclic disease. So these are all part of the TB spectrum. Just like when you have influenza running through your family, your kids might do 100% okay. Your spouse might not get any symptoms at all, but you get sick for 2 weeks. So similarly, TB also runs on a spectrum where you can have latent TB, asymptomatic TB, subclinical TB to a full-fledged infection. Okay, testing for TB. Um, in the interest of time, we'll run through this a little bit. All of you probably know who we target for testing. We look at people who are at the highest risk of infection. So who are these people? Recent immigrants, people who are incarcerated, people suffering from homelessness, um, people starting dialysis or going on immunosuppressive meds if they are diagnosed with rheumatoid arthritis or inflammatory bowel disease. This is very important because we will only be able to achieve the goal of TB elimination by addressing this population who fly under the radar because they don't have symptoms. You are not diagnosing active TB, so you have to actively screen the population. And when you do that, you prevent cases of active TB downstream, and then you prevent secondary cases. Again, some of these slides are repetitive, so I would not go over each and every word here, and we'll keep going. We have talked about this a little bit already. Um, how do you screen for latent TB? Either by doing a PPD or one of the um, interferon gamma release assays. So this is how a PPD is done. I'm not sure how many of you are still doing it. We do it very, very rarely. Now I have to peg around and see which clinic is still doing it. In our organization, it's the only clinic that does PPD anymore is the occupational health. Everybody else is doing one of the interferon gamma release assay testing. You inject the PPD, call them back couple days later, and what you measure is induration, the area of hardness related to the PPD injection, not the redness. How do you interpret results of a PPD or a TB skin test? These terms are used interchangeably. Um, if a patient has HIV or have immunosuppression or they have chest x-ray which shows that may have had TB disease in the past or a very recent exposure, for them the cutoff is 5 millimeters. For most other people, it's 10 millimeters. Um, but these are all people who have a risk factor for TB, whether they are foreign born in areas of high endemicity or they are healthcare workers who may be exposed in the hospital or clinic, people who work in the lab, people with um, injection or non-injection drug use, people with medical conditions which increase your risk of progression like diabetes, end-stage renal disease, people who live in shelters or are incarcerated. Then there's a third category of patients in whom the cutoff is 15 millimeter. So, and these are people who we have not talked about. These are people who are not at risk of TB progression or even been exposed to TB. So the question is, in my mind, is why does this even exist? Do the people really need to be tested uh, if they didn't have any exposure or any risk factors? So the answer in most situations is no. TST, obviously, there are some disadvantages. Primarily, it's a two-step process. Then, of course, it's operator dependent. Nobody knows how to read it anymore. There can be false positives with BCG vaccination and certain NTM infections, although a lot of people say that my test was positive because I had BCG vaccination in childhood. After 10 years of BCG vaccination, it should not interfere with a PPD, generally speaking. It can cause false negative in somebody who has immunosuppression or malnutrition related immunodeficiency. It can be a false negative in very young children and older people. Of course, incorrect storage of specimen can lead to a um, attenuated response because the PPD is not antigenic anymore. And recent exposure. Remember, TB is not generally an acute disease, but it by definition is a subacute or a chronic disease. So in a healthcare facility, if you get exposed, people panic very quickly and they want tests done the same day or the next day. So you spend a lot of time counseling them that PPD will not turn positive till about 8 weeks later. So we'll do a baseline for you to see if you are positive from before, but the real test to see if you have acquired TB infection after your recent exposure happens 8 weeks after exposure. IGRAs or interferon gamma release assays. Nobody can say that, so we call them IGRAs. These come in two flavors. quantiferon TB golden tube test and TB spot test. In most situations, it has replaced a TST. Even in children now, this is a little bit of a dated slide. Even in children, we are using IGRAs more than TST. And the major advantage is that it's a blood test. It's not operator dependent. It's a one-time test. You don't need to come back, and it's not affected by prior BCG. And we also don't see any boosting phenomenon with that, but that's a separate discussion. Um, so what do we do with IGRA? Same principles as PPD. All you are doing is you are checking to see if the patient is producing antibodies against TB based on a prior exposure. In PPD, you do it on the patient. You inject the antigen to which they might, if they react, means that they have antibodies to TB from a past exposure. But in IGRAs, you do it outside the body in vitro. So what you do is uh, you have um, you have the TB antigens. Instead of injecting, you put the TB antigens either in a test tube or a well, depending on which test you're using, and then you add patient's blood to it, and then you measure the response to see if they are producing any reaction to the TB antigens. So when you order a quantiferon, typically 4 test tubes are taken. Um, Blood is put in 4 test tube. This is the gray one is called a nil, which basically has no TB antigens. So it's just um, saline, and you are trying to make sure that this test is negative. So this is your negative control, which means that um, it is making sure that you are not generally producing an overwhelming interferon response for no reason. Because if you're doing that, then you will produce an overwhelming interferon response to anything, not just the TB antigen. So if your negative control shows a great interferon response, your testing has failed. You cannot use the quantiferon test. The positive control, which means that we are trying to make sure that your body is actually able to produce interferon. If you're immunosuppressed, if you have advanced stage HIV, your immunity is so low, you are on cancer chemotherapy, your immunity is so low that you cannot produce interferon at baseline, then it doesn't matter whether you have been exposed to TB or not. If you cannot produce interferon, then you will not produce interferon in response to TB antigen or any other antigen. So for a test to be valid, a negative control and a positive control have to be valid. And the other 2 test tube, the yellow and the green one, um, they they have the TB antigens lined into added to them. And when you mix the blood, you measure the interaction, you measure the interferon response based on interaction between the TB antigen in the tube and presence of antibody in the patient's blood. And if that's positive, it's reported as positive. Same concept with TB spot test. Instead of adding the antigen to the tube, you line the wells with the antigen, add the blood to it, and um, then measure the interferon response, whether the person is producing any interferon from antibody related to TB antigen or not. What's the problem with IGRA? It takes a little time. Of course, you have to handle the specimen correctly. Um, Most importantly, I think a positive test doesn't tell you that whether the patient will be one of those 10% of patients who goes on to have active TB. So that's impossible to predict. It's possible to make an educated guess, but it's impossible to predict. Treatment. We have few minutes left. So um, all interactions start with a good interview. You have to do a symptom screen first, make sure that they don't have active TB, because if they have active TB, you cannot treat them with 1 or 2 medicines. You also ask them, have you been treated with TB before, or have you had LTBI before? Because remember, once positive, a PPD and quantiferon or T-spot will always be positive. So if they have already been treated for LTBI or active TB, A positive test doesn't mean anything. Um, then you do a chest X-ray, make sure that they don't have subclinical TB. You review their different medications because one of the medications that we use for treatment of latent or active TB is rifampin or a rifampin derivative, and it has a lot of drug interactions. Counsel them on what to expect. Listen, sometimes you don't tolerate the treatment very well. Don't worry, we have other options. This is what you can expect. We will monitor your labs. If you have any problems, just call us. We are there for you. Just don't freak out. And why are we doing this? This is a very hard concept to explain to patients, that why are you giving them medicine when they are not feeling sick? So you have to spend a lot of time with them, sit down and explain to them that you have been exposed to TB, you have a 10% risk lifetime. It may be increased if you have any immunosuppressive condition or developed immunosuppressive condition later in life, or need chemotherapy or immunosuppressive medication later in life. Then your risk of getting TB or reactivating TB is very high. This is what we are trying to prevent. And remember, prevention is easier than treatment. I'm giving you one pill for 4 months or two pills for 3 months. If you develop TB, you will feel sick, you will end up in the hospital, you may need surgery, and you will be required treatment for 6 months to a year. So, what are the preferred regimens for treating latent TB? The preferred regimen is either a rifampin or a combination of isoniazid rifampin or a combination of isoniazid and another rifampin derivative called rifapentin. The reason these are preferred over isoniazid is because when we have done clinical trials, we have found that they have similar rates of efficacy, but higher rates of treatment completion, treatment tolerance, and less risk of hepatotoxicity and discontinuation of medications. So they are better tolerated, they are shorter treatments, so rifampin drugs are preferred now. If you use rifampin alone, then you use it 600 milligram daily for 4 months. Or you could do INH and rifampin together for 3 months daily. Alternatively, and many patients prefer that because what you do is use higher doses of isoniazid and rifapentin once weekly for 12 weeks. So 900 milligrams of isoniazid as compared to 300 milligram daily dose for a weekly dose, higher weekly 4 months. Or you could do INH and rifampin together for 3 months daily. Alternatively, and many patients prefer that because what you do is use higher doses of isoniazid and rifapentin once weekly for 12 weeks. So 900 milligrams of isoniazid as compared to 300 milligram daily dose for a weekly dose, higher weekly dose, 900 as compared to daily 300. Same for rifapentin, 900 milligrams of rifapentin once a week. So you take like 9 pills, but you take them the same day. And many people will feel like under the weather for a day or two after they take the pills. So many people prefer to take it over the weekend, so it doesn't interfere with their daily activities and work life. But it does shorten the duration to 12 weeks. These are the doses that we talked about. Most important adverse effect of INH, which leads to it having a secondary designation in the preferred hierarchy, hepatotoxicity. About 10 to 20% of people will get liver enzyme abnormality or get liver disease from INH. Most of it resolves quickly after discontinuation, but the rates of discontinuation are much higher for INH as compared to rifampin. Peripheral neuropathy is the other problem that we can sometimes see with INH. So if patients have underlying risk factors like HIV, pregnancy, breastfeeding, or diabetes and alcohol use, renal failure, poor nutrition, these are the people in which you supplement with vitamin B6, also called as pyridoxine, at a dose of 25 to 50 milligram per day. Rifampin can also cause hepatotoxicity, but the risk is much lower, less than 1%, about 0.5%. So much lower as compared to INH. But it can cause influenza-like illness. It can sometimes cause pruritus, itching, nausea, anorexia, and it has a lot of drug interactions. So INH has, or isoniazid has a lot of hepatotoxicity, but rifampin has a lot of drug interactions, which sometimes make it really difficult to use. You can always adjust the dosing of antibiotics, but you know, for example, if they are taking Coumadin simultaneously, then you'll have to bump up their Coumadin dose quite a bit. If they are using contraceptives, you have to counsel them on using like an alternative form of contraception, plus counsel them that it will color their body fluids orange, most commonly urine, so that they don't freak out when they pee out orange urine, thinking that they are bleeding in the urine. So very, very common side effect. Monitoring, these are well tolerated. Most of the time, you don't need labs too much, but we do recommend some baseline testing, especially for people who have other comorbidities, which is most of the people. So you'll do a one-time test, but if it's normal, then you just see them regularly just to reassure them, make sure that they are tolerating it okay. If they develop any symptoms like they have nausea, they're vomiting, or they are feeling under the weather, or they feel pain in the right upper quadrant, or they are feeling jaundice, then you do labs and make sure they are not having hepatotoxicity or any leukopenia related to these medications. There is a CDC guide which does a much better job of explaining these things than I do. This is the link where you can get it. And with that, I will end my presentation, and hopefully there are some questions we can answer.
Okay, yes, we have several questions here, so I don't think we might get to all of them. So I'll start at the top here. Given the data about TB rates after recent immigration to US, we often speak on our team about focusing on the as a risk factor and for very focused community outreach stress, question mark.
Yeah, so we addressed that a little bit while I was presenting. So again, I think that's valid. Um, Uprooting yourself and moving to a completely different country where you may not even speak the language is stressful no matter what. Um, so there is that part to it. Plus, again, you might be living in refugee camps, or your nutrition might not be very good, or you may have undiagnosed diseases like diabetes or advanced renal failure or HIV. So we diagnose a lot of uh, medical issues in people who are newly diagnosed with TB after immigration. They may not have had access to good health care before they immigrate here. So all these factors play a role into increased risk of TB within first couple years after they immigrate. So why does a gastrectomy increase the risk for TB transmission and activation? Again, micronutrient deficiency, intestinal TB because of the decreased pH in the stomach. Okay, next one. Does alcohol dependence increase your risk of contracting TB bacteria, or only your risk of converting from latent to active? I would say both. Uh, how it increases your risk of contracting the TB bacteria, because uh, you know if you suffer from alcoholism, there is a higher risk that your social situation is kind of not very good. Um, you may be utilizing homeless shelter services, or if you get into trouble like DUI or something like that, you might be incarcerated. So I think it indirectly increases your risk of contracting the TB bacteria. But the primary effect is, hepatotoxicity and other miscellaneous effects of alcohol on the body, which increases the risk of progression to active TB. How does an antibiotic work if the bacteria is protected by granuloma? Excellent question. Fantastic question. So, granuloma is not like um, a completely fortified um, wall. it does, it's still a living and breathing tissue, so you do get penetration of drug into a granuloma. And which reminds me, and somebody put in the chat that chest X-ray from a on an LTBI patient may show a calcified granuloma on the X-ray, and that's not a normal X-ray, it's abnormal. Yes, that's a very good point. So radiologist will read it as abnormal, but from our perspective, it doesn't have the typical findings of active TB. You're seeing a granuloma, so that qualifies it as a latent TB infection, not an active TB infection. Um, Sorry about
Dr.
that.
Nagpal, can I just interject for a second here? I got a message here from Dr. Swift, so I just want to interject something
Yeah,
here.
yeah.
Something you said earlier, just to clarify. When you were talking about TSTs, that Mayo's still using TSTs instead of IGRA for occupational screening program here at Mayo. So she says that they switched to IGRA in 2019. So we just want to clarify that
Sorry, I was,
occupational
yeah,
screening at Mayo is using IGRA since 2019.
I should have um, specified occupational health at our institution, Sanford, not Mayo.
And that's what I thought I heard you say. So I just wanted to clarify because someone thought they heard you say Mayo. So
Mm.
just to clarify for our audience, just so they're not misunderstanding. So, okay, thank you.
Yeah.
I think we have time for two more. If you want to pick two more questions, or do you want me to? There's several, and
Uh,
then I can send you the questions and we can answer them and put them on the website for.
well, we have 2 minutes. Let me see how fast we can go. What is the
Okay.
percent chance of LTBI advancing to active TB? 10% without treatment. What is the chance of treated LTBI advancing to active TB? Very good question. It's not 0%. So it decreases the risk of advancement to maybe 1 or 2% from 10%, but it never eliminates it completely. There's never 100% in medicine. So very good question. Um, cold in tube was replaced by quantiferon plus and yes, that is true. So thank you for clarifying that. Um, 2024 AAP Red Book recommends IGRA testing for all ages. That is correct. As I said, that the places where we have been using IGRA is it's ever expanding list of people who we can use IGRA for. So children are no exception. Thank you for clarifying that. Could you explain why recent exposure to Mycobacterium tuberculosis is a limitation for doing IGRA? Yes. So you answered the question. Is it because it would take a certain time to develop immune response to IGRA antigen? Yes, it takes the body to produce antibodies against an antigen. So that's the correct reason. Yes. Will you give B6 every day with 3 HP or only on days that INH and rifabutin is given? Every day. If rifampin, INH, PZA, and EMB for active T causing patient sustained loss of appetite, what are the options for treatment for remaining 4 months? Um, yeah, that has to be individualized. I'm not sure if I can give you an answer that will encompass all. Um, of course, you have to make sure that uh, these medications are the real reasons why the patient is not eating. Just going from induction to maintenance therapy cuts down on a number of pills and a number of side effects. So most people will do just fine with maintenance treatment when you switch them to that. But of course, if they are starting to lose weight, sometimes you have to supplement them with artificial nutrition, put a peg tube in or NG tube in. We have had to do it sometimes. Okay, I think we are over time, so maybe just email me these questions and I will try to, you know, um,
Yep,
email
I
the
can
answers back.
email you the remainder of the questions. There's just a few more. So again, thank you so much, Dr. Nagpal, for your great presentation in answering their questions. Um, very great speaker. We always love having you. And thank you for our audience for being so engaged. Save the date for our next webinar, July 16th, 2026 with Dr.